And we are live.
Good morning. This is Senate Health and Welfare. It is Thursday, January 16th. We're continuing our sort of education on what Medicaid and healthcare system looks like. And this morning we're looking at Medicaid 101 with Nolan Langwell. And we have Ashley Berliner. Thank you for coming, Ashley, up on the screen with us. Nolan, I'll put it in your hands. Actually, oh wait, before we begin, Ashley is here for the first time and we have new committee members. So let's go around and introduce ourselves again. Senator Cummings, go right ahead.
With me, Ann Cummings. I've been here before, so
Yeah.
I think Ashley and I have crossed paths.
Oh, this way. Hello, Ashley, Senator Gulick. Nice to see you again.
Jenny Lyons, Chittenden Southeast.
Sam Douglas from Orleans County.
Senator Larry Hart from Orange County.
And Nolan Langwell, the Joint Fiscal Office.
So, and we'll turn it over to you.
So for the record, Nolan Langwell, the Joint Fiscal Office, and Ashley, I'll let Ashley introduce herself.
I'm Ashley Berliner. I'm the Director of Medicaid Policy for the Agency of Human Services.
So Ashley and I have tag teamed this presentation many times in the past. I'm pleased that she is here again to do this presentation with me, because generally what happens is people start asking questions about, weedy things around eligibility or specifics about our Medicaid waiver, and Ashley is the person who has all the answers for that stuff. So we're going to tag team this. I'm going to share my screen. And when it's Ashley's turn, when it's your turn to speak, if you want me to,
Okay.
if you want me to change the slide,
Thank you.
tell me to change the slide.
You just hit OK behind you, then I won't have to climb over you. Thank you.
Perfect.
Okay. I made this disclaimer the other day. I'm going to make this disclaimer again. Some of the data is a little outdated. We try to use the most up-to-date data that's available at the moment. So if you see data from 2020 or 2021, that's because some of that data are not available at this time. That's my disclaimer. We're going to talk about, I'm going to start high level, and then we're going to work our way down to the weeds. So same chart I showed you the other day. Different is today, we're going to talk about that black upper left corner, the 24% of Medicaid, just again to get you a sense of what segment of the market we're talking about. So this is, again, I showed the slide the other day, but I want to bring it home a little bit more. This is a little bit older, but point is still the same. Top two, the top two where it says government coverage, that's Medicare and Medicaid. So Medicare is the top ray and Medicaid is the bottom or the middle one. And so combined they're 30% in 2008. If you fast forward to 2021, that 30% has turned into 45%. And then 60%, which was commercial coverage, dropped to 49%. So you can see that there was a big shift in that period. Most of it, not all of it, but most of it was a shift between public and private insurance. There's a lot of factors I think we talked about the other day. One major factor is just we have an aging population, but there are a lot of other factors that are happening too. There's what are we doing in terms of what's the federal government doing in terms of subsidies? What's the state doing in terms of subsidies? What's happening? So, but I don't know what that trend looks like today, because the last data I have for this in 2021, but I thought it was still important to sort of show how there has been some movement in the past, and I look forward to seeing what that might look like today.
Government coverage, you obviously purposely didn't tease out like federal versus state.
This is just high level. This is basically this slide, the two black ones
Okay.
combined. So I'm not getting into the difference, but it's really just Medicare and Medicaid.
Yeah.
And then commercial.
Okay.
And then the white up top is uninsured. You can see our uninsured rate also dropped quite a bit.
Yeah.
That's another thing I would love to see. Did our uninsured rate change after the pandemic?
Right.
Hopefully, it's my understanding that the Vermont Household Health Insurance Survey is in the budget adjustment, and that they are doing it this year, and we would hopefully have the results of that within 6 to 8 or 9 months. So I look forward to seeing it. So what is Medicaid? Well, again, I did this slide the other day, but you can never hammer this home enough. Medicaid and Medicare are not the same. I think everyone in this room knows this and understands this, so I'm not going to spend a lot of time on it. I did talk a little bit about the history of Medicaid. What's that?
Can I look at the slide? Maybe I should put it on my computer so I can toggle myself.
Okay.
I want
What's,
to look at one of the other slides
oh,
a little bit longer.
with Medicare, Medicaid?
Yeah, it's good. I can.
In 1964, that was the high school debate topic for the year.
What, it was?
In 1964, a federally funded health insurance program for seniors was the national debate topic for high school debaters.
I don't remember it. I was born that year.
I was debating it.
I don't remember it.
I won't tell you.
I'm sure it
where
has.
I won't tell you where it was.
And, the general underlying theme of this is, again, is if you've seen one Medicaid program, you've seen one Medicaid program. And I'll keep coming back to that as we talk about what our Medicaid program looks like and what are the optional versus mandatory. Again, this is all repeat, but never hurts. 80 million people nationwide are on Medicaid. We have 197,000 Vermonters who have received some form of services through Medicaid. Again, about a quarter of folks get it as their primary. If you combine that with the people who get partial, and it's a third. The partial people are, example would be folks on the exchange who are receiving subsidies. They have a private health insurance product, so Medicaid not their primary, but they're receiving they're receiving federal subsidies, but they're also getting state subsidies, and that's run through our Medicaid program. Another example would be Medicare beneficiaries who are receiving our VFARM. Basically what that is those are Medicare, and that's their primary. We're through VFARM program, we're providing prescription drug assistance, helping them pay their Part D premiums, cover their donut hole, etc. So we have a combination of folks who have it as their primary, and then also some folks who the state provides supplemental or assistance to folks who are moderate or lower income.
And we fixed the Medicaid to Medicare cliff last year, right? It was when you switch, if you were on Medicaid and you hit 65 and you switched to Medicare, there was a sudden loss in benefit levels. And I don't remember what we did, except it was expensive and we fixed it.
Are you talking about the shared savings program? Or
No, this was Michael Fisher. He's been trying to do it.
The Quimby, Slimby,
Oh, the
QI1,
Quimby.
we're not gonna go there.
well,
No,
well, wait.
I remember Quimby, yes.
Yeah. I'm gonna pass it to Ashley to talk about eligibility.
Okay.
Thank you. So in Vermont, Medicaid eligibility, while in Vermont, everywhere in the United States, Medicaid eligibility is contingent on state residency. So you have to.
hear her okay?
It's
No.
echo.
Ashley,
It's a little muffled.
your sound is muffled and echoey a little bit. Is there a way to fine tune it?
Yeah. Give me 1 second. Nolan, go ahead.
Okay, so I'll just go until her sounds better, and then she can jump in.
Okay.
So eligibility, who is covered, in Vermont, you have to be a Vermont resident. You have to be a US citizen, permanent resident, or non-citizen with lawful presence. Your financial situation would be characterized as low income or very low income, and be one of the following: pregnant, responsible for a child 18 years or younger, blind, have a disability, or are a family caretaker of someone with a disability, or 65 years and older. So again, low income or very low income, and those categories. We also have the Affordable Care Act allowed coverage for new adults and for folks who do not fall into these categories above but are low income. This was the expansion population under the Affordable Care Act. And then we have our benefits. Ashley, are you back online?
I am. Can you hear me all right?
That's better.
Yeah.
Yes.
okay. So in Vermont, we actually cover, of course, all the mandatory services, but we also cover all of the optional services. Sorry, Nolan, maybe I didn't follow you. You're on slide 11. Oh, there we go. Okay. And so this list of optional services here is what CMS says states have the option to cover. And we have elected to cover all of them.
Okay,
You'll see it's kind of,
Ashley, it's still garbled. Do we hear the first phrase and then it becomes echoey or garbled? I don't know what we can do about it.
is this any better?
If you sit where you are and speak slowly, it might help. Let's see.
Do you also maybe have an earpiece?
Okay.
Do you have an
I do
earpiece?
have an ear. I just put one in.
I don't know if that might be the problem. It does it when I put my earpiece in, it causes it, but I don't know.
Some echo.
Okay, I'm gonna go back to my computer and give me one more try. I'm so sorry.
All right. Technology is fun.
My computer doesn't love me switching from Teams to Zoom for some reason for the first of the morning. By the end of the day, it's happier.
Oh,
But you sound good now.
I sound good now?
Yeah.
Yeah.
Excellent. Okay. I did nothing different.
Just my only request is to speak slowly.
Okay.
That'd be great.
So this slide shows what the federally allowed Medicaid services are in the mandatory category and the optional category. Of course, all states are required to cover mandatory services. This is the kind of basic healthcare stuff, hospitals, doctors' offices, there are laboratory and x-ray. There are also more Medicaid specific things like transportation to medical care, early and periodic screening, diagnostic and treatment services, which are specific to children under 21. And then the optional services is an interesting list. It includes things like prescription drugs, which is a surprising service to be listed in the optional category, but there it is. Every service listed here is covered under Vermont Medicaid. We have elected for all the optional services.
And what's interesting about this gets into if you've seen one Medicaid program, you've seen one Medicaid program, because a lot of states some states don't cover some of these things. Like, for instance, we cover dental, where another state might not cover dental. Or as Senator Cummings will remember, we've done Cairo on and off multiple times. And I remember also during the more of the downturns, we've done analyses on well, how much would be saved if we cut this service or that service? And in the end, that's not where the big bucks are. The big bucks are in the mandatory services. The other services, especially when you take it in the MASH. So that's part of the conversation about if you've seen one Medicaid program, you've seen one Medicaid program. So we'll get into the finance pieces now. Now Senator Cummings is excited for this. So in 2020, Vermont, this is context. In 2020, Vermonters spent $6.4 billion in healthcare. Again, I said this the other day, I'll say it again, we don't know what the number is today because the newest expenditure analysis has not been released. I suspect it's closer to $8 billion today. This total spending across commercial, Medicare, Medicaid, out-of-pocket, total health spending by Vermonters, not just in Vermont, but elsewhere. There's two ways of looking at it, by the way. There's spendings by Vermonters, and that might include, I go to Colorado, break my leg, but my in-state insurance company's paying for it. Or you have from the provider aspect, how much money are the providers making? Well, that would count New Yorkers coming in. We tend to do things from the Vermonter standpoint because that's who we cover. So there's two angles for looking at that. We're talking about Medicaid here. It's 27% of Vermonters' health spending. That number probably has not changed, but that has state implications. I showed you the slide also the other day, but again, it never hurts to see too much. Total appropriation for government last year for fiscal year 24 was $8.7 billion. 2.3 billion of that was Medicaid, just to give you a sense of the scope. And this is all funds. This is state, federal, special. This is total spending for which we appropriate as a state, because we appropriate state and federal dollars, not just general. So again, this just is more of a visual of the $8.7 billion state appropriation. Medicaid spending is 27% of that state appropriation. It's funny because it's 27% of total spending in the state and it's 27% of the total state appropriation. Julie, you're gonna ask a question.
Okay, yeah, would you mind if I ask a question? I'm looking at the graph again, the debt service of 75.7 million. What's that?
You know, I'm not the expert on debt service, but I suspect that is just, you know, we have debt, you know, it's like we're paying interest and we have, you know, it's like when you have a credit card, right? And you have interest on your credit card, X percentage of your payment goes towards your interest.
Right, no, I know, I
I'm
know
assuming
what
that
debt service is. I was just wondering what triggers, why are we in debt and what are we in debt for?
I don't think we're in debt. I think it's just like,
Paying back
Is this just
bonds.
the state budget? Yeah, because that you're talking about
Yeah.
bonded dollars when it comes to
Bonded
capital
dollars.
projects.
Gotcha.
The capital bill, the thing that I've been
Paying back pensions.
Okay.
talking about the last 30 days in committee.
yeah, thing you have to pay regardless.
Yeah,
It is the one thing you have to pay in the budget first.
That's right.
right. OPEB, pensions.
We're talking about open.
So we have, of that $8.7 billion in the state budget, 3.17 billion of that is federal dollars. So just to get a sense of how much of our total budget is federal dollars, that's 36% of the state budget are federal funds. And Medicaid accounts for 40% of those federal dollars. So just to give you a sense again of how much of our federal dollars come in that go towards Medicaid. So it's a good chunk of it.
ARPA isn't being counted in there, is it?
This was 24, so it would count ARPA this federal, this fiscal year 20. If we appropriated, it's counted in that.
Yeah,
So,
yeah, we did.
so if you take ARPA out of it,
Into the budget as we could.
so if you take ARPA out of it.
Yeah.
The Medicaid is a larger percentage of federal funds.
When will ARPA be out?
It's gonna all be spent by next January.
Yeah.
Something like
I,
that.
it depends on the agency. I just looked at all of ANR and they're all encumbered, but they haven't spent it all. The same, and I'm sure that that's the way it is in every agency.
They're moving things around.
Yeah,
I'm not the expert on ARPA.
yeah.
I'm gonna reel back to Medicaid here.
But a lot of this got. Because you didn't check eligibility, so a lot of people stayed on Medicaid. For those, what,
We had
3
this,
years?
yeah, there was this period of time with redetermination.
Right,
It's,
and then it was federal money, so a lot of things got viewed in that 2 to 3 years.
yeah, we are out of that period.
Yeah.
On Medicaid.
We're on our own now.
Yeah, I think ARPA has to be used by January of 2026.
Yes,
It has to be used up by 2026. I know as a town level, we had to use ours up by 2026.
Yeah, it depends on where it came from.
Where it came from.
Right,
exactly.
yeah.
had to be.
So Medicaid,
So that, getting out of the, what did you call that?
rabbit hole?
The rabbit hole, okay.
Yeah.
I mean,
And as a
it's
select
you.
board, we were able to appropriate it in certain, community things that we needed. In our community building that we just get and this type of stuff to renovate it. Our food shelf in our town, that was renovated. That kind of thing. So it was-
Okay, out of the rabbit hole.
Rabbit hole is a big one too. That was a
It
big one.
is, no, it's a huge one.
Yeah, well, we were able to do so.
so Medicaid, again, was $2.3 billion total expenditures in 24. Medicaid is funded through a combination of both state and federal dollars. I think I covered this the other day, but I'm going to do it again because it never hurts to have this more than once. FMAP. You're going to hear a lot about FMAP, and that's stands for our federal medical assistance percentage. Most of our Medicaid comes through this FMAP match, where the federal government's matching costs for our service, but not all of it. Some of it are federal grants, the health department, et cetera. But most of our money, most of our federal dollars is through this FMAP. And federal matching dollars can range between 50 and 90%, depending on the program. And I'll get into that, please, in a future slide. But our total fiscal year 24 federal participation, so the federal share, accounted for 62% of all of our Medicaid spending. So FMAP is it's a more complicated formula than that, but the high level description of it basically is that it's a 3-year average of state per capita personal income compared to the national average. So it's sort of this double-edged sword in many ways, where when we see that our federal match is going up, which means that federal participation is more favorable to the state, it might be indicative of the fact that our per capita income has actually gone down. And vice versa, when our FMAP goes down and we're like, oh man, it's going to cost us more money to provide the same level of service. Well, it might also, the other side of that is that means per capita incomes are actually on the rise, right? So it's one way to think about it. And then we have, just doing a bunch of states, in terms of no state can receive more than I think 76% and less than 50%. And the states that get 50% FMAP are it's lowest you can get, and that's like your high per capita states, your Californias, your Connecticut's, New York, New Jersey's, Massachusetts. And then the states that get the highest FMAP are usually the states that have a really low per capita income. And that's, like for instance, Mississippi and West Virginia and Alabama are the lowest, have the lowest FMAP, and traditionally have it almost 77%. That's a pretty high FMAP. States also, and then just I threw in the other New England states just so you can kind of see this comparison. States also can receive an enhanced FMAP for expansion populations. So this is 3 of our major FMAPs. The top one, the first one, is just like our straight FMAP. This one is the majority of our programs are getting this match. It's 58.81% federal and 41.2% state. That translates to, like, for every $1 the state spends, we get $1.43 in federal match and a total gross of $2.43. Another way of saying that is for every $1 we put into Medicaid, we're getting $2.43 worth of service. Flip side is when times are harder and we're looking to save money in the budget and we cut $1 in Medicaid, we lose $2.43 in service. So it hurts the providers as well. We also get an enhanced match on our children's health insurance program. That's roughly 70-30. And then we get a 90-10 match on that expansion population that I talked about before, the childless new adults. That was part of the Affordable Care Act. This population didn't exist beforehand, and it was done to sort of help incentivize states to expand Medicaid. When it first passed, states that had not had any kind of Medicaid expansion were getting 100% federal match for this particular group, and then slowly worked its way down over a couple of years to 90-10. And the states that were already expanding, which was us, they gave us 80-20 on this population, and it moved up to 90-10, so within like the first 5 or 6 years, everybody was at the same place. And we're going to continue to get this match for this particular group in perpetuity. And so, because people say, well, how long will it last? Well, it'll last until Congress, repeals the Affordable Care Act and decides we don't want to do it. But in Vermont, that is about 41,000 people that were through that expansion program for whom we're getting that match. Now, for us, a lot of those people were covered prior. They were on VHAP. They might have been in Canon Health, but being in this is a lot more favorable financially for the state. This sort of shows you that history of ups and downs. Sometimes we get better, sometimes we get worse. I tried to, at one point, I think I tried to compare this to downturns and upturns, but you can kind of do it a little bit because, so you can see the gray are years where FMAP decreased. And you can see that it's sort of tied to events. So the temporary fiscal relief for states were during a period where there was a downturn. The American Recovery Investments Act was during the Great Recession, right? When then you had the Affordable Care Act, and then the last one, the 6.2% bump, well, that was during COVID. But there tended to be this relationship between the economy and then a little bit of a lag when FMAP goes down and up. So I just tried to show how like sort of the sort of historical flow of how it increases and decreases. And then this chart off to the right there just kind of shows it again over time, the blue being the federal share, the red being the state share, but it just compares with each other. And then the little light lines are when we get these FMAP bumps temporarily through ARA, through what we call the Leahy bump, and that was during the Affordable Care Act, where Leahy basically fought for states like Vermont, saying, well, we're doing all these good things. The states that didn't do expansions are getting all this money. States like Vermont that were doing it, we're just saying, good job, keep up the good work, but we're not getting any reward, we're being punished. So he was able to get us a little extra FMAP, which is not insignificant. And then we had the coronavirus relief stuff. Now we move into global commitment, and I'm going to pass it back to Ashley to talk about waivers and global commitment.
Okay, sound check. Do I sound okay?
Better.
So far.
Okay. So before I get into the specifics of Vermont's waiver, I want to talk about what an 1115 demonstration waiver is in general. So the Medicaid program is authorized through the Federal Social Security Act, and the Social Security Act codifies what is and is not allowable for a Medicaid program. 1115 waivers allow the explicit waiving of certain provisions of the Social Security Act. So when the Social Security Act says states must, if you have an 1115 waiver, you are allowed to do something different than what is codified in law. It is explicitly to provide to encourage states to provide innovation in their Medicaid programs. And it is, from the federal government's perspective, it is only allowable if it is budget neutral. So there is no situation where you can spend more on your Medicaid program than you would have spent without the waiver. It has to be budget neutral. In Vermont, our 1115 waiver is called the Global Commitment to Health, and it is currently in effect through the end of 2027. We've had it in Vermont since 2005. So it's a long-standing waiver. And Vermont is the only state in the country where its 1115 waiver encompasses the entirety of its Medicaid program. So most states do have 1115 waivers for certain provisions of their program. They might be limited to prescription drugs or limited to pre-release for incarcerated individuals or limited to kids or new adults. But in Vermont, ours is comprehensive. When we talk about Medicaid, we're talking about the waiver. Next slide. So what the waiver does for our state is really two big buckets of things. It gives us federal money that we wouldn't otherwise have to pay for things that aren't allowed under the Social Security Act. And it gives us flexibility in how we pay and how we model our program. On the money side, we get federal financial participation for populations and services that wouldn't otherwise be allowable. And those are our marketplace subsidy through the Vermont Health Connect. We have a community rehabilitation and treatment expansion benefit through the Department of Mental Health. This is the only wraparound benefit in the country that is funded through Medicaid that has no income limit at all. We got this authority in 2022. We are also providing VFarm for elderly Vermonters who need help with prescription drugs. We have the Moderate Needs Program through Choices for Care for individuals that aren't yet at that nursing facility level of care. But we see this as kind of a pre-nursing facility population to help prevent that long-term nursing home stay. And that is something that is explicitly allowed because of our waiver. We're also able to make some payments for institutions of mental disease, which are otherwise prohibited by the federal government. We have a palliative care program through the Department of Health that pays for palliative care services for terminal children. We have this big, vague category of investments, which we'll get into on a later slide. We are also setting up a substance use disorder expansion benefit that is modeled after our mental health benefit that I talked about earlier. This is something that we are planning to launch in 2026. It is not yet available, but it will provide substance use disorder treatment for individuals who are above Medicaid income eligibility up to 225% of the federal poverty level. We also, a few weeks ago, launched our permanent supportive housing pilot, which provides pre-tenancy and tenancy support services for individuals who have had a history of homelessness. And as of 1/2/2025, just very, very fresh, we have the authority, though not the state funding, to pay for up to 6 months of rent and medical respite. So that's the menu of things where we get federal dollars because of our waiver that we wouldn't be able to use Medicaid for otherwise. It's a pretty impressive list. On the flexibility side of the house, the main thing here is that we have a unique delivery model that allows DVHA, the Department of Vermont Health Access, to be set up as a managed care organization. So in most states in the country, you would have California Medicaid contracting with a Kaiser Permanente or a United Health to pay for Medicaid services, and Kaiser would do all the managed care functions. They would pay the claims, they would do the prior authorizations. In Vermont, instead of contracting with a private managed care organization, we have stood up a public managed care entity. And that allows us to take advantage of the much more flexible managed care regulations that are set out in law. You can go to the next slide.
If I can just jump in real quick. In the absence, again, just to drive home an earlier point, in the absence of the waiver, our Medicaid would be pretty simple. And I don't want to use the word bare bones, but it'd be a very simple program. And the waiver allows us to do a lot more, cover more people, provide more services within the same sort of budget neutrality. Last time I looked, there was about 47 states had some kind of waiver. Some had multiple waivers, it might be for something small, as we talked about. We used to have Choices for Care, which was for low income older folks. But we have one. We're the only state that's actually said that does a whole Medicaid program through the
And our waiver, in terms of flexibility, our waiver also allows us to participate in things like the all payer model agreement or a future ahead agreement. So it is what authorizes us paying differently for Medicaid services.
What happens in 2027 when this sunsets? Do you re-up?
Yeah, we've, as actually discussed, we've negotiated, the original global commitment waiver was 2005. We've continued to renew and revise. What the waiver looks like now is very different than what it looked like in 2005, but the underlying premise and flexibility is sort of the same. So what'll happen is in the next year or so, Ashley and her team will start talking with the federal government to start negotiating what the new one will look like.
Yeah, so we have to renew every 5 years. Unfortunately, if you note the date of our next renewal, it is going to put us in a position where we'll be negotiating with the federal government in 2008. We are very worried about that timeline. Our waiver has a lot in it that we do not think would be approved under the new administration. And so we are working really closely with the career service at CMS. We're in good company with lots of other states in terms of having our waiver expire at the end of 2027. So we are definitely trying to position ourselves defensively, but it's definitely a date that has concern.
Thank you, Ashley. That was gonna be my next question, so appreciate that.
Scary. Editorial.
So the waiver delivery model shown here is really just an illustration of how this all works in terms of our managed care function. So the Agency of Human Services sets up the single state agency. Every state has a single state Medicaid agency. That is AHS. We then have AHS contracting with the Department of Vermont Health Access to serve as a public managed care entity. And then DVA basically subcontracts to other departments and the Agency of Education in order to carry out certain provisions of the Medicaid program. So DMH, of course, is carrying out the mental health functions. VDH is doing things around substance use disorder. AOE has school-based health services. Dale has choices for care and developmental services. DCF has children's integrating services and placement for children in their custody. And we should add, Department of Corrections newly will be receiving Medicaid funding for pre-release services for incarcerated individuals.
Yeah, so it's actually sort of illustrating is that our global commitment waiver touches a lot of different populations and runs through a lot of our agencies. When you start looking at the budget, particularly you start looking at this thing called the ups and downs. And the ups and downs is like this document that just shows the difference and changes in the proposed budget or budget adjustment compared to the base current. And what it'll have going across, it'll have it by section of the bill. Sections of the bill are usually tied to the agency. So DVA might have 5 sections of the budget. And, the health department has 3 sections of the budget. But then going across, it'll have fund, general fund, federal funds, special funds, and you'll see something says global commitment fund. What happens is everything that runs through global commitment is double counted, because what happens is it's matched up at the AHS secretary level. So it'll show up as federal and state there, but it'll show up as a global commitment fund in all the other agencies, because that's where it's matched. And then they're contracting, with DVA and the other agencies. So you might see this large appropriation in AHS, and then it's showing up again in pieces, state, federal, state, federal, state, federal.
So maybe give an example where would there be something in transportation?
Could be, yeah.
Okay.
Yeah. But it's sort of this, it gets confusing because it's double counted. That's because it's appropriated to the agency of, Secretary of Agency Human Services, and then it's spending authority for the other agencies. So it gets confusing, but I wanted to flag that because that's the mechanics of sort of how it works. Anything else you want to add, actually, or should I go next slide?
Next slide, unless there are questions.
The thought transportation.
Right.
Housing.
It's transportation to like services, right?
Right, yeah.
So this slide is really just a graphic of the first slide I talked about related to the global commitment waiver. It shows what is allowable without a waiver in the top half of the slide, with that green box outlining the Medicaid state plan eligible groups and the home and community-based services for designated state plan populations. Everyone in these categories has full Medicaid. They have comprehensive insurance through the state. And it would be, these programs would exist with or without our 1115 waiver. The bottom half of the slide includes limited benefit groups. So, you know, a wraparound for our mental health program or substance use program or drug coverage, moderate needs coverage, or the marketplace subsidy. So they do not have comprehensive insurance through Medicaid. But this provides some sort of benefit to them above normal Medicaid limits. And then in the orange, waiver only expenditures, which include investments, substance use and severe mental illness, institutions for mental disease payments. We have the palliative care program, as I said, and rent and medical respite. Everything on this bottom half is only available because our 1115 waiver allows it.
And to your earlier point or earlier question, Senator Gulick, that's all the stuff that's on the table when we're renegotiating.
So investments are always a favorite topic of legislators. And this is an extremely unique feature of Vermont's waiver. It is the envy of all Medicaid directors in the country. And it is because of our managed care-like model that we are allowed to do this. So essentially, to take us back to California, California contracts with Kaiser. They say, we're going to pay you $100 per member per month to provide Medicaid services for our Medicaid members. Kaiser then takes that $100 and only spends $90 on Medicaid services, and then they pocket the $10 as profit for their shareholders. In Vermont, when we save money, when we don't expend the full amount that we are paying, we generate savings that can then be reinvested into what we call investments. So instead of having a profit margin, we have a savings that we then get to use on things that Medicaid, even under a waiver, doesn't allow. So these are things like funding our public health lab, paying for 211, paying for hospital diversion, paying for individuals to receive assistance with specialized childcare, transitional housing out of corrections. It's a really broad list. There are 69 of them. Some of them are super tiny, some of them are huge, and all of them are things that Medicaid does not cover outside of this construct, which is why we're so held up by other states, because Medicaid directors would love something like this to be able to pay for things, and certainly legislators and administrations. The list is available here at the hyperlink, but you'll see we have about $120 million going into investments this year across 69 of them. And this is the investment is capped via our 1115 waiver. You can't hear me?
No,
No.
the hyperlink isn't working.
I'm just trying to get the link to work.
Oh, okay.
What I'll do is I will send the link to Kiki and she can post it.
Perfect. Yes.
But I can't do it right now.
Yeah.
I definitely encourage you to take a look at these investments. We are doing a lot of work at the agency right now to evaluate the effectiveness of these. A lot of them have been around since 2005. Some of them have been added. The new ones that have been added recently, we have rigorous evaluation requirements around. The older ones, we are trying to figure out how to evaluate them. We've contracted with the University of Chicago to help us think through evaluation methods for each and every one of these investments, and hope in the next couple of years that we'll have a much better sense of what investments are working and moving the needle in the way that we want, and which ones probably should be phased down. So that's something we really look forward to being able to bring in the future.
Ashley, thank you. That's really exciting to know that you're doing that. I think you've said it before, but it really resonates this time. I do have a question about quality metrics. Is there, do you have a way of looking at clinical outcomes and providing feedback for practitioners? And if you don't, I don't want to go down a rabbit hole, but it seems like it might be important to know.
Blueprint is the one doing the most with the data right now and that feedback loop to providers. We don't have anything like that on the investments. Some
Yes.
of these investments do pay for their claims based and they do pay providers directly. A lot of them are grants and they just go out in grant form to nonprofits or different entities that are carrying out certain discrete things. It's proven really hard to evaluate. So that's why we're working with the University of Chicago to help us think through which ones can we evaluate today with the information we have, and which ones do we actually need them to start collecting data before we can evaluate.
Thank you. And we are going to have the blueprint in, I think, next week with John Soroyan, so we'll be able to hear some of that.
They're doing really cool things with data, and we are trying to leverage some of that work to be for our entire Medicaid program. And we've done some really exciting things on that front. We're contracting with the University of Massachusetts to actually build us infrastructure to look at all of our Medicaid program and help us think through how things are going. And the way the Blueprint now does more discreetly, we want to be doing it on a bigger scale. So that's a huge effort that's happening at AHS right now to get better data.
And then I just throw in this, because I put in all my presentations because it's just, you can never have too many copies of it. I hope to have an updated version of this by early February when the federal government puts out new FPL levels.
So maybe what's the poverty level that allows someone to enroll in Medicaid?
Under 138% FPL, so that second column there on the second chart.
Okay, so you can see what a family of four earning $43,000 a year would then be eligible for Medicaid. So just there, enrolling in Medicaid, and you got two kids, and you have, let's say it's a traditional family of two parents and two kids. What's the difference here then between Dr. Dinosaur and Medicaid? How do they fit together?
It's a great question, and thank you for teeing it up. So Dr. Dinosaur is Medicaid. It's just our name for it for children. And Dr. Dinosaur Kids Medicaid is at a much higher percentage. So that family of four, parents have to, in order for parents to be Medicaid eligible, they have to be 138% FPL, they have 43,000 a year, but their kids can be eligible up to 317% of the federal poverty. So if you're making 93,000 a year, your kids are eligible even though you're not.
If I'm working a minimum wage job, 40 hours a week, how does that translate into an annual wage? I don't know.
You take your hourly, you multiply it by 28.
I don't know what it is. So what's the minimum wage now?
10.
Is it?
No, it's over 10 now, I think.
It's what is it? What is the minimum wage? Do we know?
10.50 or something.
It's at least 10.50.
So let's make it simple.
That's what's up.
Make it 10.
1047.
Well, let's just say that you are at 300% of federal poverty. That's 45,
Mhm.
180. Divide that by 2080.
1367.
And that's $21.86 an hour.
Wow.
So 300% of federal poverty, you're making $21 an hour.
As of January 1st, 2025, minimum wage is $14.01.
Oh, wow. Okay.
So that translates to $29,000 a year. So you fall as an individual just under 200% of federal poverty. Now, if you have two kids and you're married and that's your total income because your other person doesn't work, then you move down to, then you'd be well below 100% of federal poverty.
Yeah.
When do you age out of Dr. Dinosaur?
When you hit 18.
18.
Yeah.
19 is in Vermont. Sorry, Nolan.
Sorry,
What, I didn't hear what you said, Ashley.
19.
18 and under.
What, so, but someone who's up to the age of 26 can be under the umbrella of commercial insurance. It's
Right.
different than that.
Someone asked the same question
I
in
know,
house the other day, because there's a lot of ages and stuff.
Yeah.
I think there's a bill for that.
age distinctions and rules, yeah, it's hard to.
Being a veteran.
It's the only bill up there.
More questions for Ashley while we have her up there and for Nolan while we have him here.
Questions, Ed? I don't.
No
So-
questions? They'll pop up sooner or later. I guess the one question that I asked, will ask going forward is related to our reimbursement rates. And I know that, there's always the discussion about Medicaid is under reimbursed and commercial is then put under pressure. How do we, rectify that? So at some point, we'll want to get into that conversation. Ashley, we're planning on having some folks in who have some national expertise and have done research in this area. But we would like very much to have you engaged in this, both you and Nolan, so we can understand Vermont.
And one thing I'll flag too is next week is the emergency board meeting. And there is an emergency board motion. And one of the things that we include in the motion is every 1% of reimbursement increase translates to X dollars.
Oh, right.
So just to have a sense of like, every 1% will cost X dollars. So that's in the motion. I don't have it in front of me, but the other thing I want to say before we sign off is that, I'm going to send Kiki to post, a couple of years ago, I did a global commitment issue brief. This is just like, what is global commitment? High level. I'll send it to her. I'm also going to post, I'd also, when we renewed the waiver, I did like a little brief, like what's in the new waiver? What makes it so special? So I'm going to send that as well. And the third thing I'll send is a list of the global commitment investments.
Okay, terrific. Any of those briefs that you have, I know they're on your webpage, but it'd be great if we could.
I'll send them to Kiki. She'll post them. So if
Yeah,
anybody wants to
that'd
see
be awesome.
them, you can just go back and look at them.
Perfect. Well, good. This has been terrific. Thank you, Nolan, and thank you, Ashley. That's been really helpful.
You're welcome.
We're going to take a break until 10:15.